So the next speaker is Dr. Vassilios Bezzerides, who's a colleague of myself and Dr. Walsh in the EP division, and I'm delighted he's going to speak to us this morning. I think a question that many people ask us when they first come to the clinic, often because they may have seen things on the internet or things they've heard from other physicians who they've seen, is what exactly is long QT syndrome? What does it mean? What does the Q and the T mean? So I think that's a very important thing for us to cover this morning. So Vassilios is going to give us a 20-minute overview of the molecular genetics behind long QT syndrome and what exactly does it all mean, what's it all about. Vassilios, thank you very much.
So I'd like to thank both Dominic and Ed Walsh for allowing me to speak today. And I'd like to speak a little bit about the overview, thinking about long QT from both a molecular and genetic standpoint, and trying to understand some of the basics to give us a framework to talk about the disease itself. So first, I'd like to talk a little bit about the basics of the cardiac conduction system, which I think is very important to try to understand overall how long QT fits into the normal cardiac physiology, and then, of course, how it's deranged. I'm going to talk a little bit about ion channels themselves and ion fluxes, and try to understand and give a basic framework for us to understand what is the QT and how it relates to the proteins that actually govern the electrical physiology of the cell. I'm going to talk a little bit about structure of the ion protein channels themselves, although not spend too much time on this, but I think it's instructive to think a little bit about this. And then finally, look a little bit and talk a little bit about the relationships of genes themselves, then mutations that we often see in long QT. So to give a sort of a framework, some vocabulary to try to understand what this disease is all about. So first, in order to talk about the cardiac conduction system, or rather how it gets deranged, we have to talk about normal physiology, or the normal conduction system. So as I usually talk about, the conduction system itself starts up with a series of cells in the right upper corner of the heart that's referred to the sinoatrial node. And I like to think of this as the conductor of an orchestra. So the conductor, if it wants things to go fast, he conducts more quickly, and if he wants things to go more slowly, he conducts more slowly, and the entire rest of the orchestra follows along. And that's the same here. If the patient is sleeping, the SA node goes more slowly, and if the patient is exercising or active, it goes more quickly. So what that does is it creates electrical activity through the upper chambers of the of the heart, that creates the upper chambers to contract in a coordinated fashion. This then coalesces on a relay station known as the atrioventricular node, or the AV node, and then conduction through the AV node then occurs through down special conducting fibers down to get the lower chambers to contract, and again in a coordinated fashion. And then the entire system resets itself over time after the conduction of the lower chambers. And in fact, it's this, as Dr. Walsh was saying, this PQRST, which was the labels that were given to the various portions of the EKG, and in fact is what we talk about as the QT interval. So what is the QT interval? So the QT interval is the measurement between the onset of the, I don't know if there's a pointer, the onset of the, I guess there's no this one. The onset of the Q wave, or onset of the lower chambers contracting, and then to the end of the T wave. And so this is the measurement of both the, if you will, of the contraction of the entire lower chambers, or the ventricles, and then the recovery time, or the repolarization. So in long QT syndrome, it's this QT interval which is prolonged, and therefore relates to the actual disease itself. And we'll talk about what goes into prolonging the QT itself. So again, with the normal, on the EKG, the normal QRS, and then T interval is depicted there. And what this is related to is actually the functions of the myocytes themselves. So if we zoom in on a set of the heart, you actually see that the cardiomyocytes are arranged in a sort of connected linear fashion. And if you look at each individual myocyte, they produce a single electrical impulse called an action potential. And this action potential is related to the cure, the surface EKG, and then also related directly to the QT interval. So it's the duration of the action potential is directly related to the QT interval. And so what creates the action potential? So it turns out that there's been a tremendous amount of work over the last 20 years, as Dr. Walsh was saying, of trying to understand what is the molecular determinants of the action potential. And one of, I think, the key things that has come over the many years is that it's not just one ion flux, but in fact it's many. It's a combination of sodium, calcium, and potassium going in and out of the cell that creates the action potential. And when deranged, or rather derangements in any one of these can cause there to be alterations in the action potential and therefore the QT and set people up for arrhythmia. So what are the proteins that are responsible? So the membranes of all cells are actually impermeant to ions. So at baseline, ions can't simply go in and out of the membrane. They're like fatty membranes, and ions can't cross. And so over evolution, there have been creation of channels in the membranes that have allowed ions in a coordinated fashion to cross through the membrane and then change the electrical activity of the cell. And so the typical cartoon that we see is on the left, where there's a pore created by protein structures that allows ions to pass through it, much like just a channel. And on the right side, you can see this sort of structure, which we won't spend too much time, but to know that the proteins themselves form have multiple subunits that allow the channel or allow the protein to have capacity to allow ions to flow through the system. And there are many places where you can have potential mutations that would affect that flow of ions across. Again, through lots and lots of work over the last 10 years, we actually know what these proteins look like through X-ray crystallography, and you can see here some very beautiful examples of how they appear like an inverted TP structure, and again, ultimately allowing ions to cross through the membrane. You can get very complicated, and I won't go into this, but if you can cross your eyes like the magic posters, you can actually see this in 3D. But again, people have worked very hard in trying to understand what these look like, because the structure of the proteins is going to govern very much their function. And again, when they're deranged, if you have mutations, trying to understand that gives us a better insight into potential how things are deranged, as well as also potential therapies. So what is the basics of how the physiology works itself? So as I said, there's multiple ions, but the three primary ones are sodium, potassium, and calcium. And in many cases, just sodium and potassium. And so all cells have sodium and potassium inside the cell and outside the cell. And very simply, there's higher potassium inside of cells than outside, and higher sodium outside than inside. So there's simply a balance, a separation of those ions between the inside and outside. It's just that simple. And in fact, it's the balance of the sodium coming into the cell that creates the first part of the action potential, or when the things start to contract. And then it's calcium coming in, prolongs it a little bit, and it provides the contraction of the cell itself. And then ultimately, in order to reset itself, potassium must leave the cell in order for the system to completely reset. So sodium comes in, allows the cells to start to contract. Calcium provides the energy for contraction, and then the whole system resets itself with potassium leaving the cell. And then it gets ready for the next beat, and it resets itself again. So in fact, it's this imbalance between potassium and sodium that largely governs the prolongation of the action potential and ultimately prolongation of the QT. So if you have too little potassium leaving the cell, that will prolong the QT, or you have too much sodium coming into the cell, that will also prolong the QT. So again, while there are other things that can cause QT prolongation, or in this case, action potential prolongation, the primary ones are too little potassium or too much sodium. And so ultimately, what happens? So we know that we've now related the action potential, which is what's going on the single cell level, to the QT, which is on the EKG. So again, too much sodium or too little potassium is going to prolong the action potential and also prolong what we measure on the EKG, which is the QT interval. So Some of this is a bit there's still some ongoing research of exactly how this then generates the arrhythmia that we try to avoid. But in general, if the QT is prolonged too long, or the action potential is prolonged too long, the system, it becomes unstable. And it's this instability where you have action potentials or signals that are coming at the wrong time when the system hasn't completely reset itself that ultimately leads to the arrhythmia that we're trying to identify and avoid, and which is what Dr. Walsh had said, which is called torsade de pointe, which is this very fast, abnormal, unstable arrhythmia, which can cause people to have passing out or seizures. So again, I'll briefly overview the idea that genes inside of cells is what codes for or creates the actual protein structure. And this is the central dogma of molecular biology. If you have mutations within the genes themselves, you'll then create abnormal proteins. And it's these abnormal proteins or these mutations in abnormal proteins which ultimately has been discovered to be related to prolongation of the action potential and alterations in the physiology of these ion channels. And again, in the upper panels, you can see again the prolongation of that action potential, which happens at the single cell level, and then in the lower is a depiction of a cartoon of what kinds of measurements that we make in the laboratory to try to understand. As you can see, the normal potassium channel has these rather beautiful normal, nice big changes in current that we see, and then the mutant one is much reduced. And that honestly is a large portion of what we do in the laboratory, is try to understand what the physiology of these basic ion channels is on a single cell level, and then try to relate that back to the human physiology. So again, there's, as Dr. Walsh was saying, there's not just one, there's in fact many genes. There's now actually 12 long QT genes that have been discovered and related to patients who have prolongation of the QT, and work in more advanced genetics has actually established even more than this, although probably smaller contribution to the QT. I'm going to talk just briefly about 3, because it turns out that the vast majority of all long QT falls into 3. They're long QT1, long QT2, and long QT3, constituting about 70% or so, 75% of all patients with long QT. So just briefly, so the 2 ones that we'll talk about just briefly, a little bit more focus, is long QT1 and long QT2. These are both potassium channels, again, so too little potassium is the cause here. And as you can see, there's mutations. Each one of those little numbers is a mutation that's been discovered, and in fact there's many more, and they've really been discovered all over those channels. But predominantly the ones that, again, ultimately we have to look at the patients and their patient families to really determine exactly whether a mutation is disease causing. But those that are in those membranes, those are in those parts of the protein that cross the membrane, tend to be more problematic than others. Although some, of course, the ones that are in the loops below the cell also cause problems. And as Dr. Walsh was saying, Dravet-Lang-Nielsen syndrome is what is considered to be long QT1 and deafness. And then Ramona-Ward is those ones associated without deafness. And so mutations can occur in both situations. Long QT3 is a bit more complicated. I won't spend a long time, but just to know it's a much bigger protein. It's in fact 4 times larger than the other ones. At least the gene itself is much larger. It's one of the larger genomes genes in our genome. And mutations in it can actually cause a variety of things, not just long QT, but in things like Brugada syndrome, as Dr. Walsh was talking about, and a bunch of other problems. So it represents a very interesting protein to examine. So just to finish up, one of the other problems, and again in patients with long QT that we talk about at great length, is prolonging medications. And so why is it that prolonging medications, so these medications that are worrisome for both patients with congenital long QT and patients who don't necessarily have it, cause problems? And it turns out it's related to really one protein, and it's long QT2 protein. Again, a potassium channel that when opens, it has a pocket inside of the channel that has to be just a very promiscuous pocket and allows drugs to fit inside. And it just happens that this is the way the protein is, and so lots of little drugs can fit inside there and block the channel. And in fact, not only block the channel, but get trapped. And so it's this trapping problem that we see a lot often with patients who have congenital long QT, or again, patients who have, not necessarily, who take a long QT prolonging medication. It's this channel which gets affected often and causes the most problems. And then we also talk about exercise as being sometimes, or emotional stress or activity that can be a problem and a trigger for long QT. And the reason why this is in many cases is that in standard exercise with patients without congenital long QT syndrome, the QT shortens. And this makes sense because in order for the system to go faster, it has to reset more quickly. And so what that is often is there's several changes in the physiology, but most importantly, it's increased potassium flux that allows the system to reset itself a little more quickly. And the problem with long QT is that the shortening of the QT is somewhat impaired. And in fact, we often use the exercise test in order to try to examine this physiology in real time. But this impaired flux does not allow the QT to shorten and then can be set the system up for instability and then promote arrhythmia, which is again why we often see, depending on, of course, the gene itself, but we often see exercise or emotional stress as a trigger for patients with long QT. So just as a quick summary, so the cardiac cycle itself, excuse me, not electoral, though that would have been on Tuesday, cycle, it occurs in a stereotyped manner. In long QT syndrome, the QT on the EKG is prolonged, and QTc prolongation corresponds to a longer action potentials. The ion channels are responsible for it, and mutations within those ion channels is either generates the imbalance that we see of sodium and potassium flux in the cell, largely. And there are mutations, single mutations often in the ion channels can lead to congenital long QT. And depending on the mutation, this often we think that that's related to the severity, although there are almost certainly other factors that are related that are still under investigation. And finally, we do know that environmental triggers are the most, or one of the most potent triggers for long QT, both exercise, emotional stress, and long QT prolonging agents and drugs, and which is why avoidance of these is critical in patients with congenital long QT. Does anyone have any questions? So the question was that the location of the mutation itself can correlate with the phenotype, and this is true. There are mutations that we sometimes see that are not. We often call them variants of unknown significance. In other words, there's a mutation, there's a variant, but it doesn't necessarily cause a problem. I think Dr. Amy Roberts will talk a little bit more about the kinds of mutations you can have. You can have mutations which are called silent mutations, which are essentially a switch of the genetic code, but it codes for the same exact amino acid. The protein is the same, but there's a switch at the level of the genetics. There are certainly other ones where you only see problems in the setting of drugs, where you don't see it at baseline, but when people take these QT prolonging agents, it's much, much worse. And so I think that we're still very much at the early days, even though we've identified a number of mutations, of really understanding exactly how this correlates with human physiology, because it's just very, very complicated. And I think as much as we like to think that we understand this, I think we don't actually, and there's a lot of work to be done in trying to correlate where the mutation is and trying to understand the phenotype.
Can you go back to what you were saying about the potassium and the genetic mutation, the class 2 mutation? Was there a correlation between those
Class 2
two?
mutation or the long QT2?
Is there a difference?
So the reason I ask is, so the question was talking about in potassium channels. So the reason we say class 2 mutations is that actually is a way that people have tried to understand how severe a mutation is. So we say class 1 mutation is likely to cause disease, or has been correlated with a human, maybe family with disease. Class 2 may or may not cause disease. This is one of those mutations where it's in an area which is concerning, but it's never been reported to cause disease. And then class 3 is thought to not cause disease. The problems with all those classifications is really only based on a little bit of the understanding of the protein, but also you have to eventually correlate it to an actual patient. You can't just look at the protein 100% and make a prediction. We're just not there yet. And there are certain research that we're trying to do in order to help make that connection. But ultimately, we're still at the level of, and this is the important part, is that we have to look at the family, we have to look at the patients, and we cannot just base everything on the genetics, although again, it's helpful, and ultimately correlating them together makes the most sense. I don't know if that answered your question, but. So no, okay. So the question was, does the potassium have anything to do with genetic mutation? The potassium itself is what governs the repolarization, or rather the resetting of the ion channel of the whole system itself. Yes. So the mutations that we see in potassium channels will reduce the flux of potassium in the cell. So if you have a mutation that either affects the ability of the channel to open properly, or ability of the channel to allow potassium to go through properly, ultimately it will result in reduced potassium influx and then prolongation of the QT. So exactly, so mutations themselves affect the flux of those ions. I'll let Christina.
I'll go here, thanks. Is the potassium and sodium imbalance, does that have anything to do with dietary things, or is it only the way that the channels in your body uses it?
That's a great question. So years ago, people used to think, and in certain cases, we have used potassium supplementation in order to treat it, but in the end, the body itself is very good at balancing at least through the kidneys, the sodium and potassium in the blood, and it really is at the level of the channel that largely governs the flux itself. So no, that's a good question. We don't think although it is true that severe imbalances, too low potassium, can certainly make things worse, and that's why we do recommend that patients, if they do have dehydration or what have you, that it is important to maintain hydration and to maintain appropriate salts in your blood.
Hi. So you described the QT prolonging agents as being kind of stuck in the channels and clogging them up. I was just wondering if there's any desire on the part of drug manufacturers to make derivatives that don't do this, or if there's much communication between you guys doing the basic research on this and other more general drug manufacturers.
So the question was, is the medications that we use often, or some of the medications that are out there, do prolong the QT because it said they get trapped within the channel itself. And so in fact, the drug companies have to make every drug that is approved by the FDA has to go through a very rigorous process of looking at its effect on that particular channel, which is long QT2, also known as hERG. And in fact, a huge portion of the cost of developing a drug is directly on that, in that each drug has to be able to be effective at the protein of choice, or the target, 20 times more than that ion channel. And in fact, if a drug causes prolongation of the action potential, or the QT, by affecting that hERG protein, it will not be approved by the FDA. And so there's sort of a cutoff that each drug is allowed to have, but if it goes over, then either it will have a warning or it will simply not be approved. But what happens more commonly is, in fact, drugs, they make it past the screen, and then we find out that they still cause agents, or drugs that are still very effective for infections, for instance, still need to be used, and so we have a caveat often that we just have to continue to use the medication, but we have to have monitoring.
There was a question. Did you have a question on there as well?
I have another one. Sorry. Could you just go back to what you were saying about the dehydration in regards to potassium? Could that lead to looking like a long QT on medication?
That's a great question. So we do sometimes see low potassium patients who are dehydrated severely, and it has to be quite severe to have a look like on an EKG with it. However, if you have a normal, otherwise normal channels, if you will, and no congenital long QT, most of those patients, almost all those patients, when you rehydrate them appropriately and the balances get back to normal, everything looks okay. So yes, we do sometimes see it, and that's why, as Dr. Walsh was saying, we've become very vigilant about screening patients and looking at all those EKGs in our hospital. And if there is a prolonged QT, we'll call up the doctor and say, you know, is it possible that patient's dehydrated, or are they very ill, are they breathing, do they have very much problems? And if they do, please, you know, check an EKG when they're done. So yes, we do sometimes, that can be it. But often when we're making the diagnosis of long QT, we make sure that all of that's settled before we go and make any measurements. Exactly. So the question was emotional stress causing long QT. I don't know if Dr. Abrams will also talk about this, but certainly in particular, long QT2 has been highly correlated with emotional stress, usually rapid emotional stress, alarm clocks and the like, to be a trigger for that. And what we believe is that there is, again, another kind of imbalance within the cell related to the adrenaline, if you will. Adrenaline is a strong trigger for the changing the QT and raising the heart rate. And if there's an imbalance in the ability for the cell to respond to adrenaline, again, to try to shorten that QT or just to cause a significant imbalance, that's what we believe to be one of the triggers for long QT, which is why, in fact, beta blockers are the mainstay of therapy, because they mitigate some of that, the adrenaline response, if you will.
There's one more question, and then we'll have to move on to that. We have other questions.
It's kind of related to what you were just talking about. Is anyone looking into, or is it possible that those of us with long QT have something genetic or in our metabolism that counteracts it?
So the question is that patients with long QT, do they have something in their metabolism that counteracts it? Do you mean counteracts the
potential negative? Like, is anyone even looking into that? Or?
So in other words, how did evolution allow these to continue? Is that the idea? Is there an advantage for long QT?
No. Is there something that, like a check and balance?
Yeah.
Oh, yes. I see. No, there are genetic modifiers that make things a little bit better for patients with long QT.
Yes.
Yeah. So I think that this is a very active area of research, and in fact, there have been a number of publications coming from places here in Boston and elsewhere, looking specifically at other what we call modifying genes. These are probably genes that occur in a much lower prevalence than the 12 that I put up there. And have a much smaller contribution, but there are clearly patients, and this is something that we're actively pursuing, who have what you would consider to be a severe mutation, that the phenotype, that is the actual QT, is actually rather mild, or rather they don't have much symptoms. And I think that this is an active area of research of trying to understand which patients are going to, based on just a mutation, are going to do fine, and which patients maybe have more severe symptoms. And it's a very complex problem and a very complex physiology that we're just trying to understand. But you're right, there's almost certainly other genes that contribute to both positive and negative of those 12 that I put up there. All right, thank you very much.